Oh, ladies and gentlemen, it's now my pleasure to introduce our next session, which will be a fantastic session. It's really a panel, a multidisciplinary team performing efficiently and to scope of practice. So they're going to be discussing, they're from the Kotara Clinic, but I'm not going to introduce them. I'm going to introduce the person who's running the panel. Hello anyway, but this panel is chaired by Jacqui Richmond, and Jacqui is, oh, she's so much. She is a highly qualified registered nurse. She's completed a PhD. She has led development of many key professional documents. In 2016 to 17, she was involved in facilitating and supporting the consultation for the development of the APNA career education framework. Currently, she is the Executive Officer of the Eastern Melbourne Primary Healthcare Collaborative. Please welcome Jacqui to the stage.
Thank you very much, Jean. No, I've got this. I'm wired for sound. Thank you very much, Jean, and thank you all very much for staying this fine Saturday afternoon. I realised that when I got off the plane this morning from Melbourne, I was literally blinded by the sunlight because it was so sunny and so blue that we haven't seen the sun for a while, and it's only May. So it's with great pleasure that I'm going to facilitate this panel, but this is also up to you out there because this is your opportunity to understand how a multidisciplinary team works and functions, and what can you take home from this panel and implant it into your workplaces first thing on Monday morning. I haven't been here. I flew up this morning because it was my daughter's 8th birthday yesterday, and we have a festival for her birthday. It lasts approximately 2 weeks. So there were cakes being made daily, there was dinners being had, and when I said to her, darling, there's a conference that I'd really like to go to in Brisbane, she burst into tears. So needless to say, I stayed at home to get my Mother of the Year award because I haven't got one of them for a while. Today I missed out on her basketball game and she shot the most baskets she's ever gotten in her life, but never mind. Her father is flying to China tomorrow and he will miss the football game that I will be at 8 AM on Mother's Day. Happy Nurses Day to everybody. Florence, we're thinking of you. Happy birthday, and happy Mother's Day to everybody else out there. So we're very lucky to have this panel from Kotara Medical Practice. We have Denise, Tony, Kim and Kate. And I've actually handballed most of the work to them, which is great, isn't it? They're going to introduce themselves and provide you with a bit of background. Where I was going with that, I actually haven't been at the conference, was that I hear there's been a lot of talk about teams and how we can't function individually in healthcare. The system doesn't allow it, the patients don't allow it. For us to have any type of real impact, we need to work together as a team. And this is one example of a highly functioning multidisciplinary team. So, Denise, please tell us who you are and why you're here.
Denise. Thanks, everybody, for hanging around. It's good to see you. There was 10 people in here at the start, and Tony said, there's 10 people here. So I'm glad the rest of you turned up. I'm here. Why am I here? Well, because who would miss the APNA conference for a start?
Nicely
it's amazing.
said.
Yay,
Yes.
organizers.
Yeah, well done.
I'm a nurse practitioner in general practice. I have been working in the same general practice, which is really something considering at 50 plus, this is the longest I've ever stayed in one job in my entire working career. So it's been what, 8 years, Kim, Tony? Yeah. Something So, like that. Mm-hmm. yeah. So I'm really happy at work and have always aspired to be happy at work. And I guess I'm here because I want to share the joy.
I love sharing joy. I'm a big believer in the circle of love. Yeah. So we capture this and bring it all up here. Denise, thank you very much. Tony?
Mm-hmm. Hi, I'm Tony. So I'm one of the general practitioners at our practice. It's Kotara Family Practice, by the way. So we like the family feel of
yes.
our practice. It's Kim and I started the business probably because I came from a partnership in a big practice that I wasn't happy in, and I wasn't happy with the values, and So we wanted to set up a values-based practice, and I guess I should also disclose that I was really strongly motivated to get into primary healthcare, is what I like to call it, because I did my registered nursing training with a terrific group of nurse educators from the University of Western Sydney at Hawkesbury campus, and they were just so passionate about primary healthcare and about you know, the declarations made at Alma Ata and the Ottawa Charter and things like that that we would talk about all the time through our nursing education, and I believed it. I think it's the most important aspect of our health system. I think it's where we can make the biggest difference, and I love it.
Fantastic. Well, there you go. You don't hear that very often, do you? I'm going to jump to Kate, because Kim is then going to just put up some slides. So Kate.
So my name's Kate. I'm a registered nurse. I'm probably new to primary care nursing, so I've been with the practice for 18 months. And I agree with Tony. I love the fact of preventative health. It's a warm place to work and nurturing, and it's good. Yeah. Sorry.
Excellent. Thank you, Kate. So Kim.
I'm Kim. I should say, even though at the start on the previous slide it said Dr. Kim Isaac, I'm not a medical doctor. I'm actually a speech pathologist by training, so I'm allied health. I do have a PhD. I have always loved the sort of business management side of the businesses that I was in as a speech pathologist, and so when Tony and I were discussing the prospect of setting up our own practice, it really excited me to take on the role of managing the practice. I tried to be a speech pathologist and practice manager at the same time, but it was just way too difficult. So I just full-time manage the practice, and I love it. I love this team that we work with. We have an amazing team of GPs and nurses and administrative staff at the practice. And so I'm really grateful that you're here for us to share our experiences with you, and I hope you get a lot out of it. Please ask us lots of questions.
We did have an email address for people to send us questions. Nobody sent us any questions. So we feel confident sharing the love. So start thinking about questions that you've just gotten a very brief overview of the panel and who they are and how they work. But Kim's now going to give you an overview of the actual clinic and practice itself. And please feel free to ask questions. Robbie, ask a question.
No pressure, Robbie.
I've already got a question. I've got 2 questions. My gosh. Do you have the microphones? Are we prepared?
Ready?
No.
Body. Okay.
Are you right to take a question before we...
Sure.
We didn't discuss this. We didn't plan for this contingency.
Bring it on.
Thank you very much for asking a question.
Hi, I'm Margie. I'm from Yeppoon, and where is Kotara? That was my question.
Oh, that's a great question.
Exactly to my first slide.
Well, let's go to that. Thank you. What a beautiful segue.
Hey, here we are. That was not planned. So Kotara is a suburb of Newcastle, which is about 2 hours drive north of Sydney.
I'm terribly sorry.
That was the ocean.
I appear to have an issue.
Just rip it like a Band-Aid.
Ocean.
No? Okay.
The man warned me this might happen.
Okay, so Newcastle is on the coast. You guys have probably heard of Newcastle, Hunter Valley. That's where we live. There's some lovely location shots of Newcastle beaches. So Kotara is a suburb. It's probably becoming like an inner city suburb of Newcastle as Newcastle expands out towards Maitland and the Hunter Valley. Tony and I started the practice in 2009. At the time, it was just the two of us. We had 200 square metres of empty space.
Two people
And
look
me and
very
Tony.
small in 200 square metres.
And I would lie awake at night, almost every night in the process, going, oh my God, how are we going to fill this? How are we going to pay for this? Anyway, Tony was very positive about it all and saying, it's okay, people will come. And they did.
Yeah.
So we have now we outgrew where we started our 200 square metres in Kotara, and we moved down the road into Westfield Shopping Centre, which has actually been a really great move for the practice. We're bigger than we were, but we still have been able to maintain our family values in the practice, and
just a bit of dust. Well, there's a little construction happening in Westfields recently. Just a little dust.
Yeah, that's right. Westfields is expanding, but that's okay. So this is our lovely new practice. We've been in Westfield now for about 2 years. These are our nursing areas. So we've got a dedicated treatment room and a dedicated nurse office, which I'm sure Denise and Kate and our other nurses are really happy about. It's a paediatric immunisation room. Some lovely snaps of the team in action. These were taken for some cinema advertising that we've just recently done, but they're really lovely shots. There we go. And this is our whole team. So we have a team of admin staff. We actually have 5 nurses. Everybody works part-time, essentially. So Denise is with us 2 days a week. We have 3 registered nurses, so Kate, Anna and Lorraine, and we have an enrolled nurse as well, endorsed enrolled nurse. We tried to encourage our other nurses to come along, but they were way too scared to talk in front of a big group of people. And we have a team of 10 doctors, including 3 registrars. So there we go. That's our team. Our active patients, we have almost 9,000 active patients, if we count that. So I think the College of General Practitioners count active patients as having had 3 visits in 2 years, but I think all of us agree that there's a whole lot of people who would still consider themselves patients of your practice, even though they've only been once in 2 years. So I'm pretty sure I did this extract by looking at patients who've been once in a 2-year period. So we have almost 9,000 active patients. We've got a really nice spread of age groups. Kotara is a relatively sort of a suburb where there's a lot of young families moving in, but we still have a pretty significant older population as well. So I think that reflects in our demographics. So we have a big chunk of sort of 30 to 50-year-olds, and then a whole lot of children coming through, as well as older population. So there we go. That's a little synopsis of us.
Any questions? Oh, fabulous. 2. I've actually got a question, so I'm in charge. No.
She has a mic.
Yeah, I do.
Be on the mic.
Facing the right way. I'm really interested. You've got 5 nurses, a nurse practitioner, 3 registered nurses and an enrolled nurse. Mm-hmm. Talk to me about scope of practice. Talk to me about when a patient comes in, who do they see?
I'll take that one.
Yeah, just jump in.
Sure.
Usually they see whoever they've requested to see. Okay. So we do have patients who ring and specifically want to see me, the nurse practitioner, or one of the GPs. Yeah.
Or even the enrolled nurse.
Or even, yes, sometimes they ring up because they want to see Fran, because Fran manages my wounds. Yeah. Only Fran.
Okay.
So they, or even with chronic disease management, some of the patients get really accustomed to that continuity with one of the registered nurses. So the patients, when they come, they see who they have requested to see. Now, sometimes we work as a team. So occasionally, Tony will be seeing someone who he decides he's going to start them on insulin, he'll knock on my door or see if I'm free and introduce me to them and say, do you have time? We can see by the book if you have time or not, but we will often make those connections, and the patient will book or, need this person to come back for an iron infusion, and we'll do what I think the Americans would call like a soft handover, a transfer. Let you meet this person, and I guess in the earlier days, when nurses were kind of new to general practice, we often felt like when the doctors sort of endorsed us to the patients were quicker to trust us. So that warm handover works really well. Conversely, occasionally there will be a patient who I am seeing and they need something that's outside of my scope of practice. I hope nobody cringes when I say that word scope of practice, because I was talking to a nurse last night who said, if somebody talks about scope of practice one more time, my head's going to explode.
Is that a dirty word?
We have been talking about it a lot this weekend. But there are patients who come that are, for example, nurse practitioners are not able to request a pelvic ultrasound under the current Medicare arrangements. You can request it, but Medicare is not going to pay for it unless a GP requests it. So there will be times when I'll, have to pick up the phone and get one of the GPs to come in, and so we kind of share the care of the patients. But I also would say that we have different roles at Kotara Family Practice, and the beauty of the nurse practitioner role is the way Medicare currently funds general practice, as we all know, the frustrations of it. What we're often missing is time with patients. Much of what we want to do, health coaching, behavior modification support, requires time. And it's not really well funded, So my role in the practice would be really for a lot of the time-consuming activities. The vast majority of the consultations that I'm involved in are 30 to 45 minutes long, and would be things like smoking cessation and health coaching and iron infusions that take a long time. And this model gives the practice a way to recoup some of that cost of time in general practice. So really, the more timely it is, the more it fits into sort of my workspace.
Okay.
Yeah, I agree with that. I think every role, even the practice manager and the doctor's roles, all have a written specific scope of practice, I guess, or description. But there's also, I guess, some assumed roles that have happened along the way. Do you think? And I guess it depends on people's interests and whether you're getting results, whether they function effectively in that role. And so, for instance, our enrolled nurse, Fran, has taken on wounds really strongly and wound care, and she's good at it.
Yep.
And she gets terrific results, and so we kind of run with that. She's and she's aware of when it's uncomfortable and out of her comfort range, and you get help. And same with junior doctors. They've got to recognise that. I guess we're all primary health clinicians in some way. We're all practitioners of primary health care, and there'll be some things that we feel really comfortable managing, and I guess our role is to identify when we're not comfortable and seek help, and that happens. I need to refer on too. Yeah,
I think that's a very important message, isn't it, for all health practitioners? If you follow those basic rules, you don't get into trouble. There was questions. Oh, I'm overwhelmed by questions. So, 1, 2, 3, 4. Matt, can I get you back up there?
2.
Yeah.
Sorry, I've got the microphone now.
Yes. I'm trying to. I'm in charge, Matt.
Denise, I was speaking to you at lunchtime, and you told me you're from quite a privileged demographic.
Yes.
Even so, who could know about all the nurses' scope of practice in your clinic, do you find that what's your patient's perception of your different roles? Do you know, for instance, my clinic's been around for a long time and I never have a nurse. It's been around for 35 or more years. Very privileged people too, very well educated people. And I've just had a nurse in the last 7 months and that's me. And if I have a stethoscope on, they think I'm a new registrar. And I have to carefully explain I'm a nurse. How do your patients perceive you? Do you know, have you had any feedback about that, about your role? And
we wear uniforms. So we didn't used to wear uniforms. We moved to uniforms. I think it would be possible for patients to confuse me with a medical practitioner in the absence of a uniform. I'm proud to be a nurse. You know, you start to develop your 1-minute elevator speech as a nurse practitioner for some way of explaining how it is that you can write a prescription for them. And I think after a while, the patients do understand. They know what you can do for them, basically, and they'll keep coming back to you for that once, you know, they've figured it out. And again, I'm going to say it's heartening that the GPs slowly, but some slowly, some quickly, you know, embrace the skills that you bring, whether it be, you know, our wonderful enrolled nurse who has mad wound care skills. The GPs have embraced that. You know, what do you think? And I think that is the thing about an effective, highly functioning team is you recognize each other's strengths, and at the same time are not afraid to expose your gaps in knowledge. You know, we try to share information. We've got really good electronic communication within the practice, and one of the things I think Kim was going to talk about was, you know, we have really regular team meetings where we work through stuff. But getting back to your question, I digress. I think the patients, if you did a survey, this is just well, I don't know, Kate, you can say too, I think the nurses wouldn't, to be honest, differentiate that much. Not the vast majority wouldn't differentiate between us, the, you know, enrolled nurses, registered nurses, nurse practitioners. Except maybe the more savvy ones would, when they know they need a prescription and they can come and see me and get in often quickly and often get in on the day. Which they can generally, we have pretty good access, like rarely do we have to knock patients back for an appointment on the day. It's pretty good access. It helps having the 3 registrars. But I think the patients wouldn't necessarily differentiate. What do you think, Kate?
No, I think they treat us
No.
the same.
I think to patients, kind of a nurse is a nurse and a nurse. And if you're a nurse who can give me a prescription, beauty.
Yeah.
Or that
I would
pathology
say to that-
request form test I need, you know, they're just happy. If you can do more for them, they're happy.
I would say that patients who are not used to having nurses in, you know, general practice can be suspicious of it, and especially older patients. So we had a doctor that joined our practice and he brought a lot of his patients with him. They were older patients, had been with him for a very, very long time with no experience with a nurse. And so suddenly they're in our practice and, you know, the nurses are going out saying, "Hi, you know, I'm Kate, I'm one of the nurses here." And they're like, "I'm not seeing you."
I'm just here to see him.
But that has changed significantly over time. So now they're mostly really embracing of it, because that's how we work. That's part of what we do, and they can see the value in it, I think, when the nurses are involved in their care. Yeah.
That's a great question. Thank you very much.
Yeah, I just wanted to ask, sorry, you spend 45 minutes with a consult as the nurse practitioner. How do you recoup your costs?
Occasionally, patients actually do pay a gap. They pay the same, the way Kim and Tony have worked it out, they pay the same gap to see the nurse practitioner as the gap that they would pay to see a GP. So no differential pricing there. Of course, there are patients who can't afford to pay for consultation, and in that case, we bulk bill them. So if you were really asking, well, how do you afford to hire a nurse practitioner, Kim and Tony, I'm going to...
Yeah, is that the... Yeah. Okay. I'm like, who was asking? It's really hard with the lights. Thank you. Okay, so I'm sure you're all aware probably of the practice incentives program, the incentive for nurses to be employed in general practice. Unfortunately, that doesn't technically cover nurse practitioners. So it does cover if you have a registered nurse and enrolled nurses. So it does make the financial case for employing a nurse practitioner a little bit more difficult because you're not getting that support from the government.
Other than the Medicare billing.
Right, that's right. So the only income that's coming in for a nurse practitioner is the Medicare billing. So if you look at it purely from that respect, you know, income in and what's going out to employ a nurse practitioner, there's probably not much of a financial case for it. But I think what you have to look at, and if you're thinking about doing a nurse practitioner course and you want to, you know, sell yourself to a general practice, the thing I think that makes Denise, in her role as a nurse practitioner, incredibly valuable to our practice is her passion for general practice and her constant thinking about preventative health and what we can be doing in our practice to improve outcomes for patients. So she's not just, you know, doing the day-to-day clinical tasks of seeing the patients, but she's very much thinking about, you know, how can we improve what we do and generating pen tool. You know, my administrative staff are like, oh my God, Denise gave me another list of patients to ring today. But that's all great, and that's all generating income if you're thinking about it from a financial point of view. But you know, you have to think of it from other points of view as well. Yeah.
And I guess, sorry, Jackie, if I could.
No, you're right.
These are so our mission statement, so to speak, and the values that we have kind of tried to work towards, and you know, these help drive the people that we employ as well. And so you know, there's a financial case, and we're running a business. We need to make money. We need to pay all those people who you saw a few slides ago, and so there's that. But then there's also some other value adding to the business that I see that Denise brings, and having nurses working in primary healthcare brings. Can I just say to the previous question as well, if you don't mind, Jackie? I think that we had some resistance from patients at the beginning to the role of nurses. Just hang in there; it gets better. And I also think it helps if the patients are hearing from, I guess, the people that they're there to, you know, if they're there to see their GP, if they're hearing from their GP, I want you to go and talk to Denise or Kate or anyone else in the practice, that's seen as you backing them up, and I think that's really important to, you know, as a kind of respect of your colleagues and respecting your skills as well. And so I think that really helps when that happens from, you know, those people in your practice. So maybe you could talk to them about that too.
Hello. Sorry. I hear that you have 2 or 3 registrars in your practice. 3. Okay. So have you ever considered, or would you consider taking trainee student nurses on clinical placements?
We have.
We do.
Yeah,
we
have. So interesting. Perfect. Is anybody here from Newcastle University? No. So Newcastle Uni, this is sad to report, but they used to have a significant primary care stream in their undergraduate nursing program, and they got rid of it.
Oh.
So we would get nurses on clinical placement when they were doing their primary care subject. We were happy to have them. We always welcomed them. But they've done away. So we haven't been approached about having a student nurse, but we loved them, welcomed them, and in fact, one of the younger registered nurses, no offense, Kate. Speaking for myself in that category.
Speaking about Kate?
one of the younger, we have a nice, lovely, enthusiastic young registered nurse working with us, and she was with us on clinical placement about 4 years ago. Yeah, and came back, and she's just been a star. She's been great. Yeah.
I also, so we haven't had any registered nurses on placement for a little while, but we regularly have medical students on placement. So at Newcastle Uni, third-year medical students have to do a general practice placement, and they're with us for about 2 weeks, and they always spend time with the nurses. That's an absolute crucial component of their time with us, and we make them aware of that, and they'll spend half a day or more with Denise, usually a couple of half days, and then they'll always spend a half a day or a day or something with Kate and our registered nurses as well, because it's really important that they get that experience of how the nurses work and how the team works together.
Anybody else moving to Newcastle? I'm going to receive my healthcare and I'm going to apply for a job. Robbie. Oh, sorry,
I've got
Karen.
a question. How do you share the workload with the registered nurse, and is Kate completely run off her feet because she gets referrals from Denise and from the doctors?
No, Kate doesn't get referrals from me.
Kate is run off your feet, eh?
Kate is run off her feet. We all are. We're all run off our feet. We work in general practice.
No, we balance it out. There's usually 2 RNs on together, plus Denise. So no, we just bounce it out together. It works really well. Someone might be doing a 75-year-old assessment, and then the other nurse will be in the treatment room, so anything that comes up that's urgent, she can accommodate that. And then, we just seem to work around it.
It's like a chaotic...
It's a sharing and caring environment, sometimes more sharing. But it works. It works. Yeah.
You like it when it's busy?
I love it busy. So I like a very busy practice, and it's a good practice, and they all eventually get looked after. Some might have to sit and wait for a little while, but we attend to them. Yeah.
We do. The nurses do have bookings.
And we watch the appointment book, and if maybe one of my patients didn't show up, or one of Kate's, and there's something to be done, we'll come and we'll look at each other's book and say, oh, I see you've got 2 people waiting, you're behind, can I do that thing for you? And they'll usually, so we keep an eye on, amongst the nurses, each other's appointment books, and try to help out. Or gosh, last week we had that day. It's like,
but I think we've got the respect there as well, that if we were to say to one of the GPs, I just can't do that now, then the GPs are more than happy to say, I've got it, don't worry about it. I can do that immunisation in my room. You keep going with what you've got. We have a lot of walk-in patients. We work in a shopping centre, so there are times when someone might walk in the door with a chest pain. So that's our priority. So what's scheduled might have to be attended to by one of the GPs. But that's how we work.
Thank you.
Hi. So sort of what I love about the clinic is that it's sort of value-based. Like, you went out of a centre that you didn't want to be in because it wasn't value-based, and you created this, and it's working really well. And one of those big values is empowerment of nursing. But, not speaking from personal experience, a lot of us, I think, work in environments that aren't value-driven, aren't value-based and value-driven, and there isn't that empowerment for nursing staff. And so I think we're looking at these treatment rooms and the way nursing staff are used, and I heard like the groan when the slide of the treatment rooms came on, all of us just being like, oh my God. So do you have any strategies then for how to try to introduce some of that thinking into an environment that might not be supportive of nursing staff, or might not understand the value that nursing staff can bring to a practice, who either might be open or are very resistant to it?
I want to say something about, I want to hear the process you guys went through, because I know they went through a real good values process. But I just want to say about having worked for the Hunter Urban Division of General Practice, and then you know, all the years through the PHNs to what it is today, and supporting nurses, that I can't tell you the number of times that a nurse has been unhappy, moved to a different practice, and found a better space. So I think, Robbie, and sometimes people just, you know, I know some of you guys who work in Broken Hill or wherever are thinking, yeah, there's one general practice, Denise, where am I going to move to? But if you do have an option, think sometimes it's easier to take your mad skills and go find that, plant yourself in that soil where you can thrive, than to try to actually change that soil that you're in, you know? Like if you, I'm trying to do the tree analogy, you know? So sometimes it's about you taking that responsibility for your own professional, you know, satisfaction and growth and development, and just trying to find your niche, find your space. And acknowledging that sometimes that's not that easy to do, but sometimes it's easier to do. It's harder to stay than it is to go.
It's scary. I mean, Tony went through that process. It's a scary process to up and leave.
I think that you're right. I was just in the last session with you and Lou and Jackie, and I was really impressed about nursing, talking about leadership and purpose and those kind of things. I think that's just fantastic for nursing, and I think it would be really difficult if you're in an awkward spot where you just, you know, the doctor's, you know, helper. I think that would be really disempowering, and so I think you could probably start by just talking about values, talking about just gently trying to nudge the bow of the ship, you know, to turn it in a different direction. But like Kim said, I was in quite a big practice, and there was you know, opportunity for innovation and changing, you know, quality improvement and things like that. But there wasn't a strong motivator for that for the existing partners that were running that practice. They were going to make all the money that they wanted to make without needing to change their practice. And so I guess you have to talk about what's the benefit of changing practice, about better patient outcomes. And I think the evidence that is starting to come out from nurse practitioners is that you know, nurse practitioners are doing really well as far as the outcomes go. And so I think you need to back it up with things like that. But I think ultimately, if you can't change that ship, then you might need to talk about what Denise is saying and move somewhere where you can. Or I can even see a time when, and already one of the speakers in that talk set up her own practice with your own values, and then you employ people based on your values. Why can't that happen? I think that will happen in the future. And I think that, you know, as a profession, nursing probably needs to start to
back ourselves.
Yeah, back yourself politically, I think, at a political level, and keep the research coming. You know, I think that really helps. And yeah, just be confident in yourself as primary health practitioners. You know, I think that's yeah, but it's hard, Robbie. I acknowledge it.
Oh, sorry, I was just going to tack on, which maybe someone can tackle. So let's say it gets to the point, because I left a clinic about 6 months ago for sort of those same reasons, and it was where I'd first started working. And I was just going to say, so if you did find yourself backed against the wall like that, because I really feel like everyone's point of view can be changed, and you can nudge at people, and you can try to innovate in every space, but let's say you get to the point where you can't, you have to leave. How do you navigate, or how did you, I guess, navigate leaving your patients? Because I think that's why a lot of people do stay in situations where maybe it's not as good, because they're your patients as well, like they're nurses' patients as well. And so how do you navigate that guilt or whatever it is? Because a big part of the reason you stay is because you know you can make change with them, even within a system that's broken or not working. and someone take this
I
away
guess you
from
can look at it maybe as an opportunity to share your experience and expertise with another group of patients who will become your patients.
That's right.
Yeah, so I know it would be hard to leave, you know, you might feel guilty about leaving those patients behind, but it's an opportunity for you to start something, you know, potentially even better with a new group of patients if you go into a place where you're more empowered and work more collaboratively with the rest of the team.
And that thinking will stop you from moving forward.
That's right.
I think you have to understand what your sole purpose is, and be confident that, you know, your patients will come with you, or that what Kim was saying, you'll be really valuable to a new group of people.
I think that encouraging organizations to become a little bit more focused on their values. I'd never worked in a place before where I went to work and they said, we're going to have a meeting to talk about our values. I was like, what? We're going to what? Oh, okay. And then going along and then it wasn't, do you know, a lot of organizations have the thing on the wall. We have a mission statement, we have a values, and it's just sitting there. But Kim and Tony have made that, have woven that really through the whole thread. So when you want to get a job at Kotara Family Practice and you're interviewed, the interview questions address these issues. When you have an annual performance review, which is a very collaborative, like, you first have to fill out your assessment, or you get to, not have to, sorry, Kim. You get to fill out your, you know, assessment about how you've gone in reaching your goals this year in the context of these values. So it's very, it's real. It's real.
Right.
They're not just words on a wall.
That's
and,
right. It has to be
that makes a
woven in.
difference. Yeah,
that's right. I mean, so many, you know, businesses and corporations these days have values and mission statements. You know, it's a bit of a buzz thing, and they might be, you know, written on the wall in the staff room, but unless they're actually lived by the team, then they don't really mean anything. So everything that we do is pretty much filtered through our values. You know, the new services that we're thinking about providing, or research that we might get involved in, or anything that we're doing, improvements that we're making, we kind of filter it through, does this fit with our values? And certainly when we're employing staff and when we're, you know, doing annual reviews and stuff as well. Absolutely.
Living and breathing it. Is somebody up the back?
Hi, yes, my name's Marianne. I actually split my life between two different practices. One's within defence. I'm never going to be able to change anything there, but they really do value nurses, so that's good. The other one is in a general practice, but in the Parliamentary Triangle in Canberra. We are owned by specialists, not just GPs, but specialists, who it's all about money. We have just got a new management company that has just come on board to manage us and make it all work. The first thing they said at the very first meeting was, all you receptionists and all you nurses, you're here to service the doctors.
Oh, that's nice.
I'm married to a doctor, and servicing is totally not a medical doctor, an academic doctor. Give me some words to go to my next breakfast meeting on Tuesday with, to be able to suggest perhaps it's different.
God.
It's terrible. Denise? Denise mentioned the other day, yesterday, there was a talk by, was it Holly Ransom?
Oh, Holly Ransom's talk, yeah.
Was that an auditorium talk? Okay, so,
yeah.
and she mentioned Simon Sinek. Yeah, so he has an excellent YouTube or a TED talk that you can find on YouTube. So that was something that really inspired us to develop our values as well. But one of the things that he does talk about is that it doesn't have to come from, you know, the corporation or the business leadership you can do that within your own teams. You know, you can sit with your nursing colleagues and just work out what is your purpose and what are your values within the nursing team. You know, if you feel like you're not going to get that change from a higher level. I guess the other thing, if you're looking at trying to find ways to argue for, you know, the development of these sorts of things, is to think about how is it going to, you know, try to find that sort of win-win-win situation. So you can present to the people at the top who, how is it going to benefit, you know, the team, how is it going to benefit the patients, how is it going to benefit the practice, and you know, the financial bottom line as well. If you can look at all of those things, then it might give them more food for thought to think about how you guys can work more in collaboration and in a more values-based approach.
And to use the words at the next team meeting about, I think I would, you know, Michelle Obama was famous for saying, when they go low, we go high. And I think you can go to the literature, which is a good, most educated people would recognize as being, you know, valid. In some cases, there's a wide body of evidence that teams function much better than individuals in health. Not just in health, in business in general. That team, you know, I think I would go to the literature about multidisciplinary, high-functioning teams, what the ingredients are, and the ingredients are not pyramids and peak people at the top of the pyramid. If that's the way the organization wants to function, they will be less productive. Not only financially productive, but also in terms of staff morale, productivity, you name it. So I think that I would try to I would try to educate them.
Yeah. Because ultimately, everyone is there to service the patients.
That's right.
Yeah,
that's right.
We have to use that word.
That old chestnut.
We're fairly idealistic, I guess. I mean, our purpose is, and we stated, is that we believe in primary health care, and I want to make a living, and I want to have a good life, and I want to look after our staff, and I want to look after the patients, and I want to enjoy doing that. That's what I want to do. A corporate, I guess, want to make money.
Yeah.
If I wanted to be rich, I probably wouldn't have been a doctor. I could have gone and done finance or something like that. I don't begrudge these people making what they want, but I also think that they can have their cake and eat it too if they play their cards right, and also value you and value the role, how nurses add to the care that's being given. I think that's just a really, I don't know what you could say at your next team meeting. That's
Excellent.
Good luck.
She's done her assignment. Well done, panel.
Maybe the doctors should get service before they come to work.
They might be happier.
Thank you.
Yeah, it was funny because when she mentioned servicing the doctors, one of my buttons came undone immediately. It was like, oh, I must be a nurse. I wanted, I'm really, really interested in your model. I think it is absolutely brilliant. And you were sitting in your 200 square metres, just the two of you at some point. Do you have like some pointers for some of us who might be thinking along the lines of that 200 square metres and two of us starting, what some of the steps might be that are really important? We obviously know that finance is important, but I'm sort of still at the point of not really even knowing how to get to that bit, if that makes sense. So do you have any hints or ideas? Can you just tell me how to do
Look,
it?
we didn't start here, so this has been a journey. So we had our 200 square metres.
How long ago was that, Kim?
9 years ago.
Okay.
So July 2009.
That they painted. Every square centimetre of.
So Tony was in a practice, as he said, and was coming home unhappy frequently and frustrated at not being able to move ahead with ideas and innovations, initiatives for improvements, and the idea of starting something on our own was scary, but it had to be done. We had to make that step, but I guess when you're starting out, we were just like, okay, let's just build a general practice and we'll employ people, and we did, and I guess at that point in time you're just trying to build up. You're trying to get doctors and you're trying to get patients, and so we didn't really have. We had a purpose of what we wanted to achieve, but we didn't really have clear values, and so some of the staff that came on board with us. We found out down the track that they didn't really fit with the values that were starting to emerge in our practice. About 5 years in, we have a fantastic accountant who's been a really amazing mentor for us as well. And about 5 years in, he said, Kim and Tony, you are just not aligned on where you're heading. And we'd hit a wall, essentially. And so he put us in touch with a business coach, and that was the best thing we've ever done. We were really sceptical about that at first, like, what are we going to talk about? I have nothing to talk about today. But then, 3 hours into the meeting, he'd be like, okay, we need to wrap this up. I'm like, oh, really? There's so much more we can talk about. So we spent probably about 6 months with the business coach, just working out, what are we trying to achieve and getting our values together. And that's when we came back as a practice and we talked about those values. Some of those staff that we had on board that weren't really aligned with that took the opportunity to move on. And now whenever we employ people, we are always employing based on those values. And so I would suggest that if you take that journey, that you maybe try to do this from the beginning. Because I think it's been really great. Like, once we had those values really clear, people actually start to want to be part of the practice.
I reckon you've got a room full right here.
I would say watch Field of Dreams, build it and they will come. I think.
Always.
Yeah, it's true. There's a certain point at which you just have to believe, isn't it? That you build it and
So look, there's lots of challenges with that, and employing key staff is really important, and building. We got to a point probably about 18 months after we opened where we needed to move, and then we're about 2 years in. We doubled the size of the practice, and 2 years and we're full, and we could do it again if we wanted to, but I don't know.
Too tight.
just might. But so it was a build, but I think the way that patients and staff responded was, it created the business model to be stronger. But you have to do your due diligence.
Yeah, and surround yourself with good mentors too.
Yeah.
Hi, my name's Leslie. Fantastic model, and the fact that you're valuing nurses is wonderful. But I'm still a believer that we're the slave nation of nurses. We do the work. We're not good enough to ride on the bus. Profits go to upwards. We do an incredible amount of work so that you can have a higher turnover of people you see, and all the work is flicked out. We still come up with more diagnosis and put things in, and I think I still worry that high turnover comes from good nurses doing good work and it all being palmed out to us. And I can see that by employing a nurse practitioner, because we're unemployable, nobody wants us on the Medicare items we return. So you're rolling some of your profits back into your nursing staff, which is wonderful. Do you share some of the profits and things with nurses? Because for you to claim that many item numbers and for them doing the work, and I think our hourly rates as nurses is pathetic, absolutely pathetic for the responsibility. We do the GP management plans, we do the health assessment, we do the diagnostic work, the bloods, the iron infusions, the suturing, we do everything, and somebody casts their eye on and then claims a huge number and drives off in the BMW. And so I have a real issue, but from what I can see, you're employing a nurse practitioner, which would probably cost you. And so I can see some being rolled back in for the value of the skill set that you're going to get. But with the other nurses as well, is their remuneration. You can care and love each other and have all the values you want, but in the end, if you need 4 tyres on your car and you're driving off, is that value rewarded in a way that is... I think it is, because a lot of us don't want nurse practitioners, do they? They don't want us.
So, we, all our nurses are employees. Some of our doctors are employees as well. Some of them are contractors on percentages. We try to fairly remunerate all of our staff. We pay above award, but in the end, you know, we're a business as well, so we have to cover our costs, and the costs of running a general practice are pretty huge. We do try to bring some of that money back into the practice as well in terms of education support for our nurses as well. I do agree that there will be places where these guys could go where they probably would be paid more. And, you know, I would be more than happy to support them in that endeavour, but we don't want to lose them. And I think part of running a really good practice and a values-based practice is having staff loyalty as well, because of the team collaboration and the values that we have. So there's you know, more to it than a monetary gain. So I don't know what other practices pay their nurses, but we try to fairly remunerate all of our staff, because, you know, admin staff are off their feet as well, and we want to pay them fairly. The doctors need to be paid fairly, the nursing staff needs to be paid fairly, and we also have to have enough to cover rent and insurances and, you know, all
it's a
those
great
sorts of
point.
things. Yeah.
I totally agree. I'd love for the remuneration to be adequate enough that I could pay percentage to Denise, but it's just nowhere near. It wouldn't even... It's just terrible. It's just
yeah,
not
and
fair.
I guess I'm aware that if I worked in the public health system, the nurse practitioner wage would be better than what I make working in general practice. And I do have another job where I work 2 days a week in the public system and 2 days in general practice. And I am paid better in the public system. But there are rewards, in much the same way that you wouldn't hire a nurse practitioner because you can't really, there's no business case, and if you look at just the finances, it's the same for me. The reward that I get from working in general practice has value. And so I feel like I'm fairly paid relative to what you get paid working in general practice, and aware that I could get paid more to work elsewhere in the public system, but happy, and I feel fairly remunerated. Yeah.
Happiness goes a long way.
It does. It does.
As you attest to, Tony. Yeah. When you're not happy, the world's not happy.
Tony and Kim, as an innovation on top of that question, if there was a revolution with MBS and there was an item number for nurses, a generalised item number, how much would you pay per visit? How much do you think MBS should pay per visit for a nurse? And they do a variety of tasks. So
Yeah.
oftentimes when I'm timing my times with patients other than for the 707s, I am extending at least 20 minutes and then another 5 minutes after I closed as I'm taking them down the hallway and chatting to them about their health.
Yeah, yeah.
So 20, 25 minutes every day patient, multiple times a day, and even in my lunch hour, and even after 5 o'clock, and even at 8:30 before I'm actually meant to be there, and up the driveway as I'm walking to work. What MBS item, if there was a revolution in it could be an MBS item number, what would you pay me for each 25-minute visit they had? Not me, your nurses. They're great examples.
Well, MBS used to have nurse item numbers.
It was limited,
before.
but?
I know they were very, very, very limited before they brought in the PIP. I don't know. I don't really know how to answer that.
Sorry to put you on the spot,
Yeah,
but it's an innovation I thought we
just-
should think about.
Yeah. Look, I don't like
yeah.
the fee-for-service model at all. Personally, I don't like the fee-for-service model because it makes it's an incentive to drive throughput. It's the wrong incentive. It's the wrong incentive for primary care. So I like the healthcare homes model of block funding. If we can find the right model, I think I'm optimistic about the future and you know, nurses being able to be, you know, remunerated fairly for the work that they do, which is broad and vast and deep. And you
But
can't
I'm always
tie
going to be
it-
a wage earner. I'm never going to be an MBS item number claimer unless I want to become an unemployable nurse practitioner and at lots of expense to myself. So if there was a revolution and you could come up with an MBS item number, what would you, Tony and Kim, as practice owners, pay me as an MBS item number?
But AMA do have in their fee schedule have private nurse item numbers that they recommend based on, you know, 1 clinical task or 2 clinical tasks or 3 clinical tasks. I'd probably, in a way, be guided by that.
Can I call Karen?
Yeah, can I respond? There are a couple of things with that, and one of them is you can charge for nurse services anything you like, it's just the patient doesn't get a rebate. And the last time there was some tinkering with the PNIC, having that payment makes affordability of the nurse much better. It goes directly to the practice. If we went back to item numbers, what you would find that a lot of practices would then 65% of the work that you do would go to the individual doctor and not to the practice to cover the work that you do. And then the practice then gets lumped with still paying your wage and employing you. And I think what happened last time when we had tiny little item numbers was that nurses were driven by tasks. All of those items are attached to tasks. And we absolutely do not want to go back to being task-based nursing for small items. Absolutely not. It would be the one thing I think that really restricts our scope of practice. It's certainly done that in general practice. If you go into the hospital system, you go to a specialist clinic, nobody sees a specialist till they've been through the nurse-led clinic. And here we are in general practice now having to reinvent the wheel. And the reason we do that is because of the fee structure. If we change to bundle payments and if we take the PNIP, we go back to MBS items, they'll take the PNIP away. It means that nurses it won't be affordable for practices. So I think we really need to think about how that's managed.
I knew this would happen. I'm about to draw it to a close and everyone's going crazy. There you go.
Oh,
Yep.
Just thinking a little bit bigger picture, especially your reflections, Tony. Oh, here I am.
Yeah, there you are.
You know, I know that nurses are certainly working, you know, very hard. But how can you reflect on your colleagues that you left, that the funding model is actually driving clinician burnout? Can you expand on, you know, just reflecting back on the number of providers out there that are actually,
cranky.
You know, they are cranky because they're just having to see more and more patients to maintain the same sort of income, and they're burnt out. Would you?
I think it's our own responsibility to look after our mental health and our happiness in the workplace, and balancing all aspects of your life, really. And if you're not enjoying that bus ride, then you should get off it and do something about it, is what I think. You don't have to work like that, and they know that. There's a secondary gain, and it's financial, and that's why they want to work like that. So I find that, I don't feel too sorry for them. I mean, I think that they need to take responsibility for it.
And this is the last question.
This is just a statement. We're a nurse force. We have to combine together to change the model of care in Australia. I've worked in the States, I've worked in the UK, I see what it's like in general practice. The general practitioners aren't rich and they're not driving around BMWs unless they're a big company. It's all about political pressure.
Yeah.
Nothing else will work.
Yeah.
The model's wrong.
And that's why you are all members of a wonderful organisation like APNA, because that will be your voice and that political voice. I'm very sorry to have to draw this to a close. I want a snapshot, if I can please, panel. We've heard a lot about people in utter admiration of what you've been able to do and the way that you work. One take-home message that people can do first thing on Monday morning or on their Tuesday morning staff meetings. One quick thought bubble.
I'll put up the... Hey, take-home tips.
Oh! We really should have had that second teleconference. There you go. You can all just...
Know your purpose is mine. Is know why you're doing general practice or primary health care.
No, mine's going to be find your happy place, you know? Find the place where you fit based on your values. Know your values and find the place. Ask them when you go for a job interview about their values, what's important to them.
Yeah. So values, obviously, I think that's our thing. I think it's really important to be in a team where everyone is seen as part of the team. I know from just other general practices that I know about, often if they have a team function that, you know, the doctors are here and the nurses are here, or the doctors get to invite their partners, but everyone else has to, you know, doesn't get to do that.
Sit at the kids' table.
Yeah. So I don't know, in our practice we're very much all one team. Everyone is at the same level: administrative staff, nursing staff, GP staff, and everyone has fun together all through the day. We do lots of stuff together outside of the practice as well. Everyone knows about each other's families, and you know, I think that's really important to break down those barriers between groups.
Thank you. Kate?
I don't think I've got anything to add. I think it's been said. Yeah.
Absolutely. So I think if you don't have it and you can't get it, go and find it.
Yeah.
And I would suggest to you that one of the places that you should go is to the APNA Education and Career Framework. Just a little bit of cross-promotional work. There is a self-assessment tool as a part of the framework, and that is about you identifying your strengths and what you need to work on. And I think that is really important. We've heard numerous times, haven't we? Know yourself, know your own values, but also know what you want. And that is an excellent place for you to start, to be able to find the words, to be able to advocate for yourself, and then use the force. Oh. Nursing workforce, not, you know, the other force. But, you know, this is you need to take control here as well, and I think that's what we've heard from these four amazing speakers. Thank you very much for your time on a Saturday afternoon. And I think the word inspirational is overused, but this is a really inspiring model, so thank you very much.
Thank you.
Thank you.